Okay. Yeah, let us see. I think it's a straightforward OSCE, nothing much. Yeah, so this is the CTG. Can someone tell or participate in the chat box? What are the type of decelerations you see and when do you see? Similar to the case you presented, where a 32-weeker comes with decreased fetal movements, they put a CTG for this 35-weeker. Late, okay, late decelerations, okay. Cord compression, yeah, Tawheed, correct. Okay, I think most of you got it. So there are recurrent variable decelerations of cord compression. You should always be able to tease out or make out early decelerations, which happens with the head compression, and late decelerations, which are seen in uteroplacental insufficiency. Yeah, good. So this next is very simple. Uh, they might just say identify the condition and name two antenatal tests for this condition. Even they have given the diagnosis here, kind of saying that clue being it a neural tube defect. And then there can be set of questions related to what is quadruple test and what are the different strategies of these testing conditions. I see many of you answering correctly already. Just to complete the discussion, yes, it is a myelingomyelocele, and if usually one has to give to a mother with a previous sibling affection, it is 4 milligram. All of you should know. Maternal serum alpha fetoprotein acetylcholinesterase. The quadruple screening includes beta HCG, maternal serum fetoprotein, and conjugated estriol and inhibin. All of you know this. Just for the sake of the completeness, I have put this, often neglected. So this is a baby with bradycardia admitted to your unit. On examination, the baby has an annular rash over skull, neck and periorbital areas. So 25-year-old primary mother. This scenario can be like this also. 30-year-old mother with recurrent mid-trimester losses or IUDs, and you have this baby. So can anyone give the diagnosis and why it is so? So they might just show you that history, ECG, diagnosis, and can it be prevented? Let me see, most of you would have answered it correctly again. Yes, complete heart block, neonatal lupus, and what drugs are given to the mother? Okay, no, it's not moving. Okay, this is again in fetal therapy. Whenever they say don't forget to discuss this, most of the time people talk about Luto, CDH repair and this, but one of the favorite questions is fetal therapy, and fetal medical therapy is this wonderful dexamethasone which can be given to the mother to possibly arrest the progression to complete heart block when it is picked up early. Let's go to the next OSCE. I think 90% of you will be able to say what is this and what comes on the x-axis and y-axis and where do you use it. The clue is it is a statistical test, not the pulmonary graphs. So yeah, Pranika, it is ROC curve. Vinayak may be spelling a typing error. It is not RAC, it is ROC. Yes, yeah, correct. Yeah, so most of you got it correct. Just tell me what do you put on the x-axis and what do you put on the y-axis. Sensitivity and specificity. Vinayak, you're almost there. Okay. Again, we'll just. So on x-axis is sensitivity, on the y-axis it is 1 minus specificity. So what sensitivity is nothing but the true positives. And on the y-axis, we are plotting the false positives. So 1 minus specificity. Okay. So you kind of use it in the various screening tests to compare the two tests and also to see an appropriate cutoff. That is in screening test, when you're using a particular test, you want to get all the true positives while minimizing the false positives. So you choose a cutoff of, let us say 80, and say that at this particular level, it suits me best to pick up the maximum sensitivity with the least false positive rate. So spend a little time on understanding the ROC curve. Okay. Last, okay. All of you would know this. So I need not spend on what is this, but more importantly, what do these rectangles, horizontal lines? So if I move my cursor, so these are all the square boxes. This is the horizontal lines. This is the diamond, what you call, what all they indicate. And as you see, there is something called I square. Okay. And this is where it is. So this is a typical forest plot, and these days so many meta-analysis and Cochrane, everywhere it is there. So each individual study with its participant and its confidence interval. The size indicates the, depending on, bigger the size means more is the participants and more is the weightage of that particular study in the overall evidence. This is the effect of no effect line, but whenever a confidence interval is wide, it is crossing. For example, in all these studies, the confidence interval is crossing, both favoring the trophic feeding or intervention or favoring fasting. And that is why you see that the confidence interval is 0.1923 and like that. Okay. And the overall effect of this is the diamond. Now, most important is what is I square, and I square is for the heterogeneity of the studies. So lower the I square, better it is. So when there is no significant, usually I square is less than 25, and whenever it is more than 75, it is called considerable. Okay, so I'm sure you understand this. One important question, what do you mean by confidence interval? Okay, all of you should know what do you mean by confidence interval. Okay. Yeah, the final question after this will be this. So you have a study where you are evaluating CRP against blood culture. So you need to just draw a 2 by 2 box and calculate. The numbers are, among 75 neonates with positive CRP, 20 were culture positive, and 125 neonates who had negative CRP, 5 were culture positive. So what is the true positivity? What is the true negativity? That is nothing but sensitivity and specificity, the positive predictive value and the negative predictive value. Well, the mathematics part is always simple. What is more important is to draw the 2 by 2 table. And that is where most of us get kind of confused. I have just given 30 more seconds. Maybe those of you having pen and paper can draw that. And then we will see the answer. Okay, so let us see. Nothing very simple. Screen, this is how you draw. Let us say this is a screening test, positive and negative. And on this, you say this is positive and negative. Okay. So screen positive and there are disease. These are the true positives. Screen is positive, but they are not disease. These are the false positives. Those with screen negative, this having disease, they are falsely negative, and those who don't have truly the disease are the true negatives. So in this case, those with CRP positive and yet having culture positivity were 20, and those with CRP negative and having culture positive truly were disease were 5. So from this, you can pick up true positivity will be that the sensitivity was amongst the 25 babies were truly deceased. 20 were picked up by a screening tool. The sensitivity is 80%. Okay. And amongst the 175 who were not deceased, 125 were truly shown as negative on the CRP. So the sensitivity is 69%. The positive predictive value is amongst those with the positive screening test of CRP, 27, that is 20 upon 75, 27% were positive predictive. That's what the positive value. The negative is similarly 120 amongst the 125. So it has a high negative value and a positive predictive value. The small rider is the positive predictive value, negative predictive value also depend upon the prevalence of the condition. The same test, if you apply in an unit or in an area where there is high sepsis rate, obviously it will have a higher positive predictive value. So then comes the other terminologies, which is the likelihood ratio, positive and negative. That also one needs to know. But I have not included in the OSCE, but all those who are exam going should read how to assess a diagnostic test. And the common terminologies are sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratio positive and likelihood ratio negative. So this was a brief OSCE, very simple. It is kind of a revision. And with that, I just stop here. Yeah, yes, sir.
Yeah.
From my side.
Thank you. Yeah, it was very nice, Oski. I think you concentrate on statistics, so that's a good thing. It's a nice revision for them, simple definitions and sensitivities and specificities. Yeah, so hopefully all the students had a good learning experience from this feat. Yeah, thank you both the presenters, Dr. Sai Ramya and Dr. Nishi from Mumbai. Both of you have done really good presentation. Thank you. And Dr. Sai Kiran, thank you for accepting to be the faculty and conducting the OSCEs.
Thank you, sir. Thank you, Rajesh. Thank you. Thank you, everyone. Good night. Good night.
Good night. Thank you all.